Welcome to the third info clip. We're going to look at whether we're any closer to a potential cure for HIV and developments in treatments and vaccines against the virus. Before we can explore these issues though, we need to consider again current treatments for HIV. Human immunodeficiency virus, HIV, is a retrovirus that once in the bloodstream targets a certain group of white blood cells called T cells. These cells form part of the body's initial defense against infection, acting as the early warning system that then allows the immune system to respond to and deal with the invading infection. Once HIV invades the T cell, it codes the cell so that it will synthesize and make more HIV particles to then leave the cell and seek more unaffected T cells to recode them and make more HIV, and so on. So that over time the immune system is weakened and overwhelmed by the HIV. In the developed world, without medication, this process would take between 2 to 5 years. So, the medicines, antiretroviral treatments, work on several levels to stop the integration of HIV with the T cells, stopping the process of recoding and stopping the formation of new HIV particles, thereby preventing replication, suppressing the virus, and allowing the immune system to remain healthy and continue to fight infections, as in someone without HIV. The effectiveness of treatment can be measured by monitoring the viral load, the amount of HIV circulating in the blood, and the T cell count, the measurement of T cells not affected by the HIV. The viral load is thought to be directly proportional to how infectious the person is, so the lower the viral load, the less likely they are to pass on the infection. Should, for example, a condom break when having sex with an HIV-negative partner. So, some have suggested that if a positive person is compliant with their anti-HIV meds, then over time, surely the virus would be suppressed enough that it would be eradicated from their system. Unfortunately, this is not the case. The antiretroviral drugs only fight the active T cells, those making more HIV, and can't detect the inactive T cells, those where the virus is integrated into the T cells' genes but not actually replicating. Like it's in a dormant phase, so remains hidden within the immune system. A new study from Howard Hughes Medical Institute in the US, published recently in the journal Cell, suggests these reservoirs of inactive T cells may actually be 60 times higher than previously thought. Thus far, there has been one recorded case of a cure for HIV. This occurred in 2011 on a patient called Timothy Ray Brown, also known as the Berlin patient. As well as being HIV positive, he was dying from a rare form of leukemia, and apparently had every trace of HIV infection removed from his body by undergoing a radical bone marrow transplant containing T cells genetically modified to be resistant to HIV infection. The procedure, however, nearly killed him. There have been several other similar transplant-type case studies recently presented at medical conferences using less toxic treatment regimes than that used with Brown, that seem to have had some success. But a third case, in Minnesota, the 12-year-old boy was unsuccessful after the donor cells turned against the host body and he died inside 3 months of the procedure. We also don't know whether these isolated cases are actually cured or just in remission, and the HIV could perhaps return in the future. There is a group of patients, however, that are referred to as long-term non-progressors, or more recently referred to as elite controllers. Rare individuals who are infected with HIV but control the infection without the need for antiretroviral therapy. Many of these patients have been positive for 30 years or more without progressing to the point of needing to take medication in order to stop the development of AIDS. A lot of research has focused on these non-progressors as to why their immune system seems to be able to fight the HIV without the need for medication. Unfortunately, what's been found is they have increased levels of other virus-fighting proteins, such as interferon alpha, which create symptoms of their own, including malaise, a general weakness, and the increased risk of cardiovascular disease. A recent French study, the Visconti trial, has found that a group of 26 adult patients who started taking anti-HIV medicines within 10 weeks of their infection with HIV and took the medicine for a substantive period, on average 3 years, and then stopped, largely did not restart. In 8 cases they stopped completely, and have maintained undetectable viral loads for a period of 4 to 10 years since stopping therapy. The theory is that the antiretroviral therapy is given quickly and maintained for long enough that the viral reservoir, mentioned earlier, remains small. In normal HIV infection, even people on antiretrovirals have residual HIV infection, so that if they stop their medicines, the cells are stimulated to produce a new burst of HIV with a disastrous crash on their T-cell counts. Sometimes, not so conventional cures are suggested to clear HIV from the system. The most far-reached reported to us in clinic has been one gentleman who was using toxic tree frog poison to inject into himself, causing his body to fight the toxin, and in so doing, his belief was it would purge his body of HIV. Such non-proven and unresearched cures can be highly dangerous and are not recommended. Faith, blessing, prayer, exorcism are also not effective cures for HIV. Whilst organised religion and faith communities can provide a strong social support for people living with HIV, it's important that healthcare professionals work with religious leaders to assist them to help individuals use their faith with adherence to their medication regimes. So what about a vaccine to prevent HIV infection in the first place? There are a number of vaccine trials in progress at present. One showing promise is a trial using rhesus monkeys reported in the journal Nature in October of this year. The study looked at the monkey equivalent to HIV, simian immunodeficiency virus, or SIV, which was encapsulated inside a monkey version of cytomegalovirus. This acted like a mock vaccine. The shell of the CMV was used to infect cells, but deliver instructions for making proteins to fight the other virus, the SIV. These proteins themselves cannot fight the SIV, but prime the immune system so that when the real infection comes along, it is immediately recognised and contained. 46 rhesus monkeys were given the vaccine. Then, 13 months later, they were exposed to SIV. 24 male and female monkeys with up to 10 weekly shots of the virus in the rectum to mimic anal sex, 16 females similarly infected vaginally, and 6 with up to 3 direct low-dose injections of SIV to mimic needle sharing. They did all acquire SIV, as blood and cellular assays taken soon after showed the infection. Unfortunately, just under half the monkeys, 48%, developed SIV with high viral loads, which means without antiretroviral therapy, they would most likely die within 2 years. However, the good news, for the other half, whilst they showed SIV in their cells, it was a very weak infection of low infectivity, so biologically pathetic. The monkeys did not even need to mount an immune response to the infection, so didn't actually make antibodies, and would test negative if tested for SIV. What's exciting about this vaccine trial is that in such low-level infections, we know over time the virus would disappear. And these are animal studies and not directly relevant to humans, although it's promising and the research continues. So in reality, while we're making some good progress, we're probably still some way off either an effective, safe and cost-effective cure or a reliable and safe vaccine. Therefore, prevention remains better than cure, and as we stated last time, condoms remain our best form of defense.